I think the thing to keep in mind is that you're the doctor and that you're the one who ultimately is responsible for giving this patient the best treatment outcome that you possibly can.
Right.
And in terms of the hierarchy of how I practice as a dentist, the number one thing that I care about the most is quality of treatment results. I want an orthodontist, any orthodontist, to look at that case and say, wow, that's awesome. I couldn't do it better myself.
Good.
And so everything that I do in my practice comes from that as my core driving principle.
Welcome to the Truth About Dentistry podcast. I am Dr. Peggy Bound, a successful solo dental practice owner in St. John, New Brunswick. After years of figuring out how I wanted to practice, I now run a fully digital clinic providing my own brand of dentistry on my own terms. It wasn't easy, and I'm still learning, but I know I have so much knowledge to share. This podcast is created to help inspire young dentists or anyone looking to transition to a more digital practice. I aim to give you actionable step-by-step strategies to help you navigate the modern dentistry landscape. If you're looking to become more digital, improve your skills, or even have a more profitable practice, then this podcast is for you. Now let's get started. Hello, everyone. Welcome back. It's so exciting to be here today. I have a very special guest. For many of you who know me, I generally do this podcast on my own. I've been trying to give you great content, telling you all about my experiences. But today I'm really excited because I get to interview one of my good friends. We've known each other for a little while. We've been doing, knew each other through the Invisalign world. And his name is Stephen Schalk. And Stephen and I really have been more recently, since I've been taking some of his courses called Clearly Aligned, have really started to develop a little bit more of an interest in talking about, what we can do. Stephen has his own podcast called the Clearly Aligned Podcast, so you should check that out as well. And if you haven't heard about Stephen's courses and you are doing Invisalign and you're interested in learning more, I believe, and I always recommend it as my top course that you can take. And so he's going to share a little bit about that course with you. And I just want to, welcome him, and he's going to give us a little bit of a background, and then I'm just going to pick his brain, and I hope you're going to get to learn more about Stephen and about Invisalign today. So here goes. So Stephen, welcome to the podcast.
Thanks for having me.
It's so nice to have you here. And of course, we chat at other times, but for the sake of this podcast, I would love for you to give our listeners a little bit of your background and kind of, how you got to doing so much Invisalign, because you are, I believe, one of the top GP providers in North America.
I haven't been paying attention to the statistics as much. Once you kind of hit a certain level, then you've hit that peak, and then you don't really pay attention. But
I
yeah,
guess, but it's pretty impressive. So,
thanks.
so I know you're right up there. And if anybody wants to get into doing more Invisalign, you're the guy to be watching, in my opinion. So I'm really excited because, of course, I do a lot of Invisalign too. But I really think that we all have a lot to learn from each other, and I want you to share with them, kind of just a little bit about your background, how you got to this point, and then we can go on further.
Yeah, absolutely. So I guess going back to where I started, I went to University of Alberta for dental school. And then from there, I started working in Grand Prairie, which is a few hours north of Edmonton. So it's freezing cold and the sun doesn't come out a whole lot. But that's where I got my start. And a partner and I, we were in the new phases of opening a practice, and I was mostly doing pediatrics. And I really, really enjoyed interacting with kids, and I saw a need for doing more phase 1 treatment. And I took a straight wire orthodontics course called Force by Richard Litt, and that really changed the way that I viewed orthodontics. Before that, I really had no interest in doing orthodontics, but it started my passion. And so I realized that it's just so cool to set up these kids' mouths with perfect dentition and set them up for life, essentially. that it's having, I don't want to say more of an impact than doing just filling on them, but it had such long-term consequences and improvements. And so I, at that point, realized that I wanted to do orthodontics, and I was looking to do a residency, but I was convinced not to by some good friends who are orthodontists who said that you're not really going to learn the future of orthodontics, which is clear aligners. And so instead, what some of these top orthodontists counseled me to do was go around the world and learn from the best of the best.
Wow. So
And
they
so,
suggested that.
yeah, I was actually told by orthodontists, don't necessarily do a
Oh,
residency.
wow.
Yeah.
That's very
And
cool.
it was. And so instead, what I did is I would travel. And so for 2 to 3 years, I would just go to any location that I could.
Yeah.
So I went to Japan and I learned from Kenji Ojima um, with the Japanese Aligner Society.
Everybody knows. I mean, if you've
Everyone
done
knows
enough
Kenji.
Invisalign, you know Kenji.
Yeah. So I took courses from him. I took all the digital smile design residency with Christian Coachman, which isn't so much aligner orthodontics, but just the
Yeah,
digital
exactly.
philosophy.
Yeah, and that's how I
I
got. That was right around when I got my real big start. I was doing a lot of Invisalign too, and it was like, wow, we
yeah,
could merge the two. You know, we could actually have a real, we can know the end and then move the teeth to this. You know, it's just incredible. So
yeah,
that's exciting.
yeah, exactly. And so I went through Spain and Europe, and then in North America, Regina Blevins is a huge mentor and friend. She's the largest Invisalign teen provider in the world.
Wow.
And Christian Fournier
Yep.
drove a lot of my aesthetic principles of lingual attachments.
Hmm.
Um, and so that really, really changed how I viewed the world of aligner orthodontics, because now we put all the attachments on the lingual for adults if they choose that option. It's super, super aesthetic.
Yeah.
Are you doing the same, Peggy?
Yeah. Well, I actually learned lingual attachments from Christian Fournier as well.
Yeah,
Because I was taking some coaching from him through I think it's called My Ortho Coach, if
your
you've
ortho
ever heard
coach.
of My
Yeah,
Ortho Coach.
yeah,
Willie Diane, I think, was the
yeah.
creator of that. And so I wanted, one-on-one feedback from about my clinchecks. And when a few times when I would usually get Christian to do my cases,
Mhm.
and him and I also were on the faculty together, so we would, we knew each other that way too. But he's just such a lovely human, and
Yes.
another great Canadian, right? Canadians
Yep.
gotta stick together. But he just, yeah, he started doing this, and I think he's one of the few orthodontists that only does clear aligners. Like he doesn't do straight wire at all, I think.
He has a few brackets and wires cases, I
But
think, when
not
I
much.
was at his office, but no, it was like 98%
Yeah,
aligners.
it's amazing. So he's, I
Yeah.
believe, also very much ahead of his game, and he's always
Oh
really
yeah.
trying to think outside the box. So that's the type of people you want to surround yourself with. And it sounds like that you did just that, right?
Oh yeah, absolutely. I love the creativity aspect of it.
Yeah.
Yeah, and then the big one for me was learning from Dr. Tarek Albiali, who
Oh, yes.
teaches at the University of Alberta. He is an Align speaker as well, and does just some of the most crazy biomechanics cases you can imagine. And so he would come to our practice. He came to our practice. He's just finishing his last cases, but I think about 4 years, maybe even we're going on 5. And I would go to Edmonton and learn directly from him,
Wow.
and almost like a little bit of a mini residency.
And then you put all the experience you had, because you seem to also been able to, in a town that did have a lot of orthodontists and a very small population, you were able to, you had very trusting patients that wanted to stay with you, and you obviously, where you're seeing a lot of younger patients, you started to really get a lot of case acceptance, and quickly you not just taking these courses, but you actually got to practice what you were learning. And how did you do that? Like, was it the way you did your consults and things like that a little more?
Well, I think one philosophy that doctors should have, as long as they're learning and progressing towards something, this isn't the right philosophy if you're not going to be engaged and trying to improve. But you don't always need to have all of the answers before you start. So, for example, if you have an 8-year-old and you're working on them, you don't necessarily need to know where that second molar is going to be positioned, because it's so many years away that you have time to set everything else up. If you think about traditional straight wire orthodontics, they're not working on the finishing bends at that first appointment when you put in your NiTi wire. So we, in some ways, I think put too much pressure on ourselves when you're first learning aligner orthodontics to try to have every step figured out. And that's not the case. And so, like you said, there's different resources that are available that you can rely on so that you can get help. And that's really where Clearly Aligned has come from, is we want to be able to jump in and help you with your problem cases,
Yep.
or cases that, yeah, exactly, that you don't necessarily need to know absolutely everything about it. In terms of the consults, one thing that I would highly recommend for doctors is not being so strict and stringent on your case fees when you're first doing something that is new. You spend all this money on education
Yeah.
and you come back to your practice, and then there's a patient in front of you and you tell them, well, now you need to pay $7,000 for this orthodontic case.
Yeah,
But
you're
really,
gonna learn from it just as much as
yeah, exactly.
yeah.
And so changing that philosophy to instead say, you know what, this is part of my education. I normally would charge maybe for that case nowadays, like I would charge $7,000, $8,000 for it. But when I was first doing something brand new, I would tell them that I want them to be part of a study case. And either I would tell them one of two things. We're going to be learning on this case. And as long as you're okay with that, there's going to be mentors involved in the process. So it's not like we're just winging it, but I have a mentor and they're going to be helping me on this.
And you're really upfront about that. So
I'd be really upfront.
I mean, you're dealing with obviously patients that have been in your practice, probably
Yes.
you have a trusting relationship with, right?
Yes, either that, or I'll tell you the other way too, but either that one. And then I tell them that because you're a study case, we'll do it for 50% of the normal fee. And they were so grateful for that. Other patients.
You can also show you know, you can be okay and you're transparent. And I think that
Yeah.
honesty with the patient and then them feeling like they're also getting something very valuable. Wow, that's
Yeah. Well, then on the flip side, though, I will say that this is the other method, is that let's say there's a case that you're pretty comfortable with. It's not like you're uncertain, but it's your first time doing it. And you know how to do it because you've seen it done through courses uh, and whatnot. But I would tell patients that I want to use their case as a study case. So this is something that I want to one day present on. And I didn't really have huge ambitions of presenting at the time, but I would tell them that if you allow me to use this case as a study case and sign over all the different photo rights for this case, then we'll go ahead and we'll give you a discount again of whatever, 30% off. Something that gave a rationale for why the price was going to be less. And so all of those patients move ahead as well. But I didn't tell them that this was going to be a new case that I don't want to say I wasn't comfortable with, but that was the first time that I was treating that particular style of case.
right.
And then again, you need to have the ability to finish the case and to have mentors that will help you with it if needed. But it's amazing because so few of those cases that I really need help in the end on.
So yeah, so there's two ways to approach that. And by doing so, you feel you got to really stretch your limits. Did you learn, like you weren't afraid to try something new? You had the trust, you had the mentors, you had the connections, and you had the consent from the patient. You weren't being dishonest with the patient, but you're also giving the patient something for their extra time and the documentation that you were taking.
Yes,
so,
exactly.
Wow. Yeah, so I love that. I think again we should all, I guess I've been a little bit like that myself, is willing to try something and I'll figure it out like as I go along. But to really say it in that way, I think a lot of doctors need to hear that, because we're never alone. I mean, we can always reach out for help, even in the middle of a case we're prepping if we had to, right? But we do feel, and I think we're intimidated in dental school, especially we're talking to new grads. They're really made to feel that they shouldn't try something because it's dangerous, or they need to refer everything. And I think I certainly respect all the specialists, but I think that, you know, sometimes the patient is going to be best served by you looking right at the case. You're really working hard at it, and you're trying to make it a win-win. So,
well, the other thing is, I think that we often don't realize that the specialists do this too. I actually have orthodontists who will message me about cases saying,
oh my God.
hey, I'm trying this new protocol that I've never done before, and I know you do it, whether it's lingual attachments or something else. And there's a lot of collaboration that goes on there. Like, hey, I'm kind of stuck on this one point. What would you recommend? And so we think that we're alone in this, that sometimes there's new procedures or techniques we're doing, but no, it's everyone is in the same boat. We're all trying to do the best for our patients possible. And the only way that you can do the best for your patients is if you continue to learn new techniques. Because if we all just kind of got stuck with 1990s orthodontics and nothing progressed and nobody ever developed their skills, then we're doing a disservice to our patients by not getting better.
Oh my gosh, absolutely. I love that. And you're really I think anyone who's listening, this is like mind blowing. So I think if they even stop listening right now, good. So let's keep going. I want to talk to you a little bit about, there's a lot of different courses they can take out there. A lot of dentists are getting into, they don't realize when they first starting doing something like Invisalign, but really knowing, I guess, or understanding the importance of like what the tooth movements do, what we do with the software, and like learning about the biomechanics and the attachments and the things that we need to do to get where we want. Because just because the computer will put it that way, a lot of dentists that I talk to, if I am helping them with a Clincheck or something, they seem to think that they don't realize that is not going to work. I mean, when you get to learn that, when you do enough cases. But can you talk a little bit, and this can be certainly a little plug, I think you should talk about your attachments and biomechanics course here. Stephen does a great job at this, but, importance of truly understanding the tooth movement and the software, what the software is capable of actually doing for us and what's really able to do clinically. What's that all about?
Sure. So, like you said, we really wouldn't, well, for me, for sure, with the attachments and biomechanics, I wouldn't have a course that I would even teach if you could just accept everything that came back from Align or whatever Align or company you're working with, because everything would work and Smile Direct Club would work and we'd all be out of jobs with Align or orthodontics. So in reality, it's a really good thing that we're still a part of the equation. We're needed. It's important for us to use our clinical judgment to make changes. I learned this from my mentors, so I can't claim credit for inventing this, but you need to look at the Clincheck as a force system being placed on the teeth. It's not what the teeth are going to do. It's what the aligners are going to try to do to the teeth, how they're going to push on the teeth. And so, for example, if you have a case with a significant deep bite, well, I'll always finish my Clincheck with an open bite. If I start with an open bite, I'm going to finish it with like an 80% deep bite, because studies show that what you ask for is only going to express maybe about 50%. And so,
an adult or in
in an adult case, in an adult case, yeah, mixed dentition cases and teen cases are different, but so I would not kind of overdo those Clinchecks as much. But understanding that kind of changes the whole way you perceive and look at the Clincheck.
Yes.
And so in the attachments and biomechanics course, I really try to go through those two different parts. What the actual, like, again, pretty much makes sense, the attachments part of it. So you need an interface on the tooth that the aligner is going to push against to make that movement happen. You can kind of think of it like if you're going into a hotel and there's a revolving door. If you go to the very middle of where that like central post of the revolving door is and you're pushing, it's really hard to push right next to that central post where the door spins on.
Analogy. Yes.
But if you go ahead and you push furthest away from that, will force times distance, that means that you have to put less energy in, less force is required in order to make that door spin, but you move a greater distance than if you're in the center of that spinning door. So understanding principles like that allow you to take control of your own Clincheck and to no longer need the optimized attachments. Because there's one part for me that makes such a big difference is it's not that optimized attachments don't work. There's lots of cases that they'll work really well. But what happens when they don't in some situations? And you need to take control because a lower premolar isn't tracking because it's so round. What do you do if that movement is very important to finish your case? If you just keep accepting what you get back from Align, you're never going to get to the finish line. You have to know what you can do to change that attachment.
Yeah, you have to really understand it.
And what you asked was, what are some parameters that don't really work? Well, I guess one thing that I disagree with, with the software is the principle of how much teeth move per aligner. Now, the software...
Not move 0.25. Was it 0.25?
0.25 millimeters. Yeah, the software allows 0.25 millimeters of movement, but it doesn't differentiate whether that's the crown moving or whether that's the root moving.
Right.
Because it's very easy to move crowns through air. That probably will move 0.25 millimeters if you're just rotating a tooth or like tipping it or putting some crown torque or something towards the buccal or the lingual. But if you're going to be moving a root through bone with an extraction case, for example, 0.25 millimeters is never going to happen. And so you need to know how to change the velocity and slow down the clincheck to make it consistent. Else they're just going to stop tracking continuously.
Yeah, I learned that too from Dr. Fournier as well. Yeah. Asking the technician and knowing what to ask, asking for the velocity to be reduced, asking for your attachments, especially your conventional anchorage attachments, to be placed at the incisal third instead of at the body. Or sometimes when they come back from the technician, they'll be up by the gum line. Like these attachments are up, and it's like, that is not going to work. Like you said, it's that great analogy by standing in the center, near the center post of the revolving door. Most of us will naturally walk to the outside of that revolving door to get through it without as much resistance, right? So
totally.
I love that. That's really good. That's great. And I mean, this course is just so thorough, Stephen. Like you've done such a good job. So I just want to, again, anybody who
thank you.
I'm not just doing this because he's not, but honestly, like,
where do I send the bag of money to?
Yeah. So funny. No, it's really good, and it's very scientific. You've tested it. And so speaking of testing things, you told a funny story when we saw you. So my team and I, a few of my team members went up to see Stephen for the foundational systems course back in January. And it was so great too to meet your family, Stephen. They were all there. It was so nice.
Likewise.
And yeah, and we had a great time. It was such a great, my team, like the team members that I brought, I wish I could have brought everyone, but it really opened their eyes and really sparked a new enthusiasm. So if you can actually bring someone to one of Stephen's courses too, or team members, I would highly recommend that. But one of the funny stories that you told us about that really, I guess, of course, struck me is that you've gone so far, not just to test things on your patients, but you've actually tested things on yourself. In a really, again, your personality is, I really want to know. And you've actually just, if you could just tell the quick story about how you've tested, I think you moved your.
Yeah, I was getting frustrated that there was so much coming out of the GP education world saying that you cannot move molars.
Yes, right. Okay, that's where it started.
Yeah, and I think that statement is just completely categorically wrong. Molars are really hard to move, but I can show you tons of cases where patients had to get a tooth pulled out because they had a bad endo, and it made sense to go ahead. And it doesn't always make sense, but it made sense to go ahead and move their second molar into their first molar position. Well, if you can't move molars, then how did we do that? Yeah. Right? And all the different expansion cases. Sorry, I should clarify. You can't move molars with aligners.
Yeah.
And so it's not that you can't do it. It's a hard movement to do. And so what I did is I wanted to show that you can. So I didn't really need aligner orthodontics. I had braces as a kid. I had maybe a little bit of relapse on my lower incisors, but yeah. So I went into treatment for a year because I wanted to experience a few different things. But first of all, I wanted to distalize my second molars, and I wanted to intrude them, because the statement too was you also couldn't intrude upper molars. And so I distalized my second molar probably 3 to 4 millimeters, and then I intruded it 3 to 4 millimeters.
Wow.
The second thing was I wanted people to stop being so scared of posterior open bites, because posterior open bites are normal. They're expected, they happen, and they're not a big deal. I say this in the course, but no orthodontist ever has woken up in the middle of the night and like grabbed their wife or their husband and said, honey, wake up. I just had a nightmare about the posterior open bite that's going on. Once you realize that having a posterior open bite is completely normal throughout treatment, you're going to have them. Probably right now, I have 15% of my patients walking around with their aligners, and right now, if we check, they'd have a posterior open bite. Yeah. I'm not going to leave them with a posterior open bite, but it's not this horrible, scary, traumatic thing. So I wanted to show that teeth that are in a posterior open bite are going to naturally super erupt back into full occlusion if given time.
Right.
And so there's some circumstances that we need to jump in and we need to either cut trays or put buttons and elastics or do more movements with the aligners.
You do that sometimes, but
totally. Okay. But in this case here, if a tooth is not in occlusion in any way, shape, or form,
Yeah.
well, what would happen? If you lost a lower first molar, we know that second molar is going to erupt into that space until it has contact, until it meets something. So I then went ahead and I just allowed that tooth, once I intruded it, to super erupt back into full occlusion. And so give it 3 months without having a liner covering that tooth, it's fully back down where it's supposed to be. Yeah. So that changed a lot of the ways that we recommend dealing with posterior open bites. Is first of all, giving them more time to settle and not going right into final viveras, but using what we call active retainers. So just aligners with no attachments on them that just allow the teeth to settle, that the patients aren't wearing full time. And then you come back often 6 months later.
And then do your retainers.
And then do your retainers, or then go ahead and put buttons and elastics on the teeth. Because I know so many doctors, if you have to, who close that open bite every single time with elastics and buttons. It's so clinically inefficient. When 9 out of 10 of those cases, you can get them to settle either just guiding them with the liners or just cutting the trays or giving them time and only jump in if needed. So I did the case for that reason first, to show that you 100% can distalize and can intrude teeth with aligners. You can move molars. Then number 2 is I learned from Christian Fournier how to do what's called a double stacked attachment, where you actually
place. I use those now, by the way.
Yeah. And so this double stacked attachments is just doubling up the thickness of the attachment. So if you have a really important movement or you need a lot of retention, you place an attachment, and then you ask the technician to place another attachment directly on top of that attachment. So now it looks kind of funny because you've got 2. So I did that on my case because I wanted to give myself the worst case you could possibly have. So when a patient complained, I could say,
I admire that. Like, truly.
So yeah, for a year. So I did this. I put double stacked attachments, and on the lower molars, again, you don't have to just have one attachment per tooth. So I placed 2 4mm attachments side by side to make one 8mm attachment. And then I double stacked it. So pretty much I almost had
8mm attachment
in width.
They'll do that, right?
But it's not actually 1 8. It's just you have 2 4s that are kind of blended into each other. Yeah.
Okay. And then, wow.
And then double stack it.
Yeah.
And then I did that on my first molar. I did that on both of my molars on the lower. Yeah. And I did on both of my premolars with a 5mm wide attachment double stack. So literally it looked like my teeth had like spoilers on them, like from like wings.
In Newfoundland, we call those spilers.
Spilers. That's great.
That's a Newfoundland plug there.
That's what I'll tell the technicians. Please put some spilers on.
Spilers.
And then what I did is I put lingual attachments on my upper, which I ate with my aligners in. Because if not, I'd bite down and hit those attachments, break them off. Right. And then I also went ahead and put a button on my upper lateral as a bootstrap.
Okay. Yeah.
Because I wanted to do a bootstrap elastic, and I did elastics, just like class 2 elastics, just very light, just to experience the elastics.
Yeah.
So I just tried to create the worst possible case that you could imagine. So then when my patients are complaining, it's like, you know what? I've been there. I know what it's like to have lingual attachments and eat with your aligners in. I know what it's like to have the double stacked and have to kind of like really work to get the aligners in and out. And I know what it's like to have those.
Initiation of becoming a provider. Okay, we might be able to change that. You can't get a provider license for Invisalign unless you experience it yourself and you do the Stephen Schalk protocol.
The crazy protocol. You know, this is a funny story from that time too. It never happened, but I was going to get another dentist in the practice to place a TAD on me, but do it without freezing. Because I was going to. So here's the thing. So we're all ready to go. And I said, let's just put some topical on, because the feeling of getting a TAD is supposed to be similar to just getting an injection. Like, it's not supposed to be that bad, but I always freeze for my TADs. So my mini screws, for those who don't know TADs. But he was going to go ahead and place the TAD on me. He's never placed a TAD before, but whatever. It's like putting a drywall screw. It's not a big deal. So I'm all numbed up. I'm in the chair, but he wasn't able to properly click the TAD. And I said to him, these are $250 a pop. So make sure that it engages properly with the TAD driver, so it doesn't fall off. So I'm laying back, he's coming, he's going to place the TAD, and he didn't engage it properly, and it falls on the floor. And so it was like, oh man. Okay. So we get the next TAD out. Okay, make sure this time it engages. Do not let that happen again. Exact same thing. And so $500 of TADs on the ground. And so then I said, finally, just screw it. We're not placing a TAD on me today.
Not meant to be.
It's not meant to be, but I was going to let him do all that.
Oh my gosh, that's so crazy. Yeah, so what you will go through any length, it sounds like, to learn, to stretch your limits, and to basically put yourself in a patient's shoes. Because, I mean, even for me, I've had so much dental work done. I was not a good child when it came to, I used to get all kinds of cavities. I've had root canals, crowns, dry socket. I've had all that happen to me. And I do feel it makes you a better general dentist, ortho, anything that where you've actually been in the patient's shoes. I think that's very valuable. So us dentists probably wouldn't put ourselves through a root canal so we could experience what that's like. At least with ortho, because it's reversible, that's brilliant.
Yeah.
Like you can really say, listen, and I ate with my aligners in as well. And when a patient says, because of your course, we actually offer it, but just the way you showed us in the consult. And 50% of people are saying that they want to do that. And I know for sure if they do that, I'm like, oh, it's going to be so much easier. And I've been through it. So I'll say to them, like, listen, I used to eat with my aligners and they're really shocked. But when they know that I've done it, it seems to impact their decision. So it's good.
Totally.
It's good.
It absolutely does.
Peggy's been there.
Yeah. Yeah. And same with your staff too. When I'm like, I placed a TAD on my wife, I placed lingual attachments on all of my staff. Like we've all been through it. Yeah,
so
totally.
Good. All right. So I'm going to ask you now, the difference, I guess, one of the things I wanted to ask you is, there's a little bit of a difference between, sometimes the parameters or things that a line is letting you do. And again, I'm not picking on a line here, but there's certain things where you are tied, like a line saying, we won't let you do this. And you understand that we can't have doctors just doing everything. There has to be some sort of guidelines, but yet you want to do what's best for your patients. So you do have some, I guess, ways to kind of manage both. Do you want to elaborate on that?
Sure.
Dealing with the limitations, but then doing what's best for your patient.
Do you want to become the modern dentist in your area? Our on-demand and live mentorship will help you stand out, attract your ideal patients, and build a niche-based practice. This A to Z training is for dentists and team who desire the digital workflows and skills to operate a thriving digital practice, helping you stand out in a crowded market. This course is the culmination of Dr. Bound's 20-plus years of experience in building a patient experience that patients will pay more for. Learn from our on-demand courses or receive a more customized experience with our mentorship program as we guide you through the curriculum. You can find out more from the link in the show notes. Or, if you aren't quite ready to take the plunge, you can also find the link to our freebie consult photography guide, which will help you get the right shot on the first attempt. Now back to the episode.
I think the thing to keep in mind is that you're the doctor and that you're the one who ultimately is responsible for giving this patient the best treatment outcome that you possibly can. And in terms of the hierarchy of how I practice as a dentist, the number one thing that I care about the most is quality of treatment results. I want an orthodontist, any orthodontist, to look at that case and say, wow, that's awesome. I couldn't do it better myself.
Good.
And so everything that I do in my practice comes from that as my core driving principle. Right. And then after that, my next driving principle is that I want to be efficient, because ultimately we do run a business. And I want it to be efficient treatment that works and that is profitable. Because if it's not, then we're going to have to close our doors, and it doesn't make sense for me to be doing this, right? Exactly. And sometimes as dentists, we don't want to admit that part, but I think it is important to know that we need to be profitable and we need to be efficient, and patients are going to appreciate our efficiency. So that's where I come from as a dentist. Now that means that I don't really care in many ways if it takes me longer to do treatment, if it gives them better results.
Mm-hmm. I think one thing just want to interject, but I think
Sure.
one thing is we're taught sometimes that we should be able to do a case in 6 months, or, I mean, again, you do that if you can, and you're going to get the result. But if it means not finishing the case ideally, and like feeling like, okay, well, we're failures if we took 18 months or 2 years to do a case, I think there was that guilt to feel like, okay, it took me so long to do this case.
Yeah,
What did I do wrong? But no, sometimes it does take time. And that's where I guess we want to reassure the listeners, like if you're doing Invisalign, try to focus on giving the patients the best quality outcome. Yeah.
totally. And patient autonomy, of course, is a major thing. I don't want to be sitting on a pedestal being holier than thou for anybody listening, being like, well,
No.
what if the patient only wants to focus on the aesthetics? Yes, absolutely.
Yeah.
Treat adults realistically.
Chief complaint.
Yeah, treat kids idealistically. You cannot, in a proper clinical standard of care, though, compromise on treating a growing patient
Yeah.
just with aesthetics. You have to treat the entire case. That's the standard of care. And so with adults, there are going to be cases where you won't necessarily treat as comprehensively, and that's okay.
Yeah.
But it doesn't mean that we shouldn't present that to them and give them the option of correcting their malocclusion as best as we can if they want that. Because some patients really care about that and some don't. But for patients who care about that, that's my top priority. And so what I recognize then is that to me, it doesn't matter as much if the case takes longer, if they're on board with that, and that's the goals of what we're doing. And it doesn't matter for using more aligners. And so for that reason, we almost always treat kind of with a 3-year comprehensive or 5-year comprehensive. We're willing to use more aligners as needed to get those results. And so that's one of the big ones is like we were both saying here, is adjusting velocities, right? We'll change the velocities of the case, which will increase the number of aligners. But the ironic thing is that if you end up treating a case and you don't change the velocity and you only make it through the first 20 of 40 aligners, and then you go off track, 20 of them are going in the garbage. And now you do the same thing again and again and again. Well, half your aligners go in the garbage. Almost none of our aligners ever go in the garbage because we are making sure that the cases are tracking and they're progressing properly. And so for that reason, like we're not scared of using 70 aligners, 80 aligners. Like it's crazy to me that we think sometimes as general dentists that we can treat a case in 6 months that would take an orthodontist 2 years in brackets and wires, because the average ortho case is 22 months. So why are we giving ourselves such horribly tight parameters of what we need to accomplish in such a short time frame? And then we quote them 6 months and it takes us 10 months. And my friend, Jeff Skinner, I need to give credit for this because he was telling me, he said, I'll finish a case in 8 months that I quoted 6 months and I'm a villain.
Yeah, it's happened to me. I was like a week past 6 months and she was upset. That happened. I couldn't believe it.
But if you quote a year and you finish in 8 months, you're a hero. So why do that to yourself? Why put these artificial parameters in place telling patients that this is the time frame? Instead, give yourself more buffer room. And if the patient is that, I guess, challenging and difficult, that they care more about just speed and they don't care about quality of results, then maybe they're not the patient that you want to be marrying for 6 months to a year. Maybe they're better off going to your competitor and they can have fun together instead. But I'll say almost no patient, we treat 300 to, depending on the year, and if I have a daughter being born that year, 300 to 400 cases a year pretty much. So I can tell you the results speak for themselves. Patients are not going to leave you and not do treatment with you if you tell them that it's going to take longer than your competitor, because we have tons of second opinions where I tell them, look, realistically, I don't want to overpromise and underdeliver. So it's going to take time to do this right. And patients, they don't want cheap. They don't want fast. What they want is they want things to be done right and they want value.
Yeah. And if you say that, I don't want to, overpromise and underdeliver, you're already seen as somebody who's more honest, and trust in our profession is one of the things that we have to fight for. So why not do things in that way where we can really build that trust from the beginning? And like you said, I used to, and of course, it is a proud moment when you do finish something sooner than you predicted. But it's also, if you're not doing things to what the patient expected, or you're not being honest with the patient about what was possible, then that is just not the way I think you and I like to practice. It's okay if someone else wants to practice that way, but I think if you really want to do things and you want to learn the effective way to treat the patient and get the results that, really would be, if an orthodontist saw them. I love that, they saw it, they say, wow, this is really good. I couldn't have done it better myself. Now you're gaining the respect. And I think as GPs, if we are there's a lot more GPs doing ortho these days, we do really need to bring up our game, and we need to be doing things in a conscious way that is ethical and just best for the patient, because it's just the right thing to do.
Yeah. Peggy, can I give your listeners, so to kind of wrap up that question, can I give your listeners a tip of something that I would do on every single case that is not a line protocol?
I was going to ask you, what was your number one hack or a hack that you recommend?
Okay, well,
but if
sure.
If there's that,
well, I'll give you this one, and then I'll give you more hacks, I guess. Okay.
They want that.
So here's one of the things then that Align doesn't have a standard protocol that I put on like every single case, because really it improves the patient experience so much and just makes the whole process so much better, is that at the end of a batch of aligners, you can request, and I know you know this, of course, but you can request for up to 4 aligners that don't do anything. They're just passive aligners. They still have the attachments on them, but what you ask for then is you ask for 4 passive aligners at the end of treatment, or if they give you any like feedback saying you cannot have passive aligners, you ask for nearly passive aligners.
Well, I used to ask for 10, and now they say they will
they'll only give you 4. Exactly. So they've changed their protocols, but you can ask for 4 nearly passive aligners at the end of the active aligners. So if you had 40 aligners, now you'd have 44. And so normally I just give them the number. Let's say you designed the Clincheck and you had 37 aligners, I would say, please keep 37 active aligners and give me 4 passive or 4 nearly passive aligners. And now what you do is when you finish that batch of aligners, you give all of your patients these 4 aligners and say, these are what's going to hold you over until your new aligners arrive. And so instead of being stuck in one disgusting, gross tray, they feel like they're continuing to progress. And you could tell them that they don't really do anything, or you could go ahead and you could just say, wear these 4 trays while your new ones are coming in, change them out once per week, and that gives you a month to go ahead and get your new aligners in.
Yeah. Okay. No, that's really good. And yes, I've been doing that for a while as well. And it's, again, sometimes Align doesn't want to give you too many. So there is something that you did mention, which was, and I think I even messaged you about it the other day, was, asking for, if a patient's going to need restorative later, or you do need even more time in, I guess, a non-active aligner, we know that if there's no attachments, especially on something like a molar, and you're asking for an extrusive movement, for example, it's probably not much likely that that's going to happen. Am I right about that? I think.
Yeah.
And so you can ask for very minuscule amounts of movement there, but it really won't happen. It won't manifest. So is that also something you do, and when do you do that?
Yeah, so this one changes constantly. So it depends probably when your listeners are listening to this, but you can, so the minimum movement now required per aligner, there's a minimum amount of velocity that a tooth has to have as a movement per tray. And I think it might be 0.05 or maybe 0.1.
I've asked for 0.1 and got 0.1.
Yeah, 0.1 is definitely within the acceptable range, but 0.1 millimeters per aligner is essentially meaning that over 10 aligners, your tooth would move a millimeter. That's kind of the baseline. So what you could do is, if you have a patient who needs restorative, but you're waiting on an implant, right? The classic problem of, do you get them the Vivera, and then do you go ahead and do all the restorative and then get them a new Vivera? It doesn't really make sense. No. So you can go ahead and like Peggy's saying, you can have them being held over in aligners with no attachments on them that don't really do a whole lot, that are just meant to stabilize the occlusion, act almost as like temporary retainers. And how you get that, because you can't just say, give me 10 aligners that don't do anything. So you could ask then for, like, if you wanted 10 of them, you could go ahead and ask for 6 active aligners and 4 passive aligners. And with the 6 active aligners, please begin by extruding the second upper right molar, 0.1 millimeter. Yeah, just one molar, 0.1 millimeter over the aligners 1, 2, and 3. And then in quad 2, on the upper left second molar, then for aligners 3, 4, 5, and 6, only extrude that tooth 0.01 millimeter for 3 aligners. So you want to be careful that you don't have the too much movement expressing, like moving an entire millimeter. The liners
That's not
might
what I
stop
did.
fitting as
I
well.
kind of screwed it up, but
It was just a little bit too much movement on those particular teeth, but you can break up the movements and say, first, I want you to move one molar, then I want you to move a different molar.
yeah.
And so those are some of the ways that you can go ahead and get more aligners as needed. The thing that I would just say is that I think why Align has changed some of their protocols is because we need to be conscious about not, I guess, taking advantage of the system.
Wasting.
Wasting.
And they're a company too. Like
Yeah,
they know a lot of times the liners just get thrown out, never get used.
totally.
So nobody wins there.
No,
So I
especially
understand
environmentally too.
I understand their side of that, like they're a business and they're not going to. But sometimes for those of us who really are doing something for a reason, a good
Yes,
reason, then it's okay. We have to do what we have to do, and we're not abusing that, I guess.
totally. And sometimes if you write what you're trying to accomplish to the text, it helps. So if you say something along the lines of, please extrude, the patient is getting restorative done, and
You can
we're
even say
not
that.
we're not going to be ready for their final viveras for another 20 weeks. Please give me 10 aligners in total, 6 of them active, 4 of them passive. We would like to settle, like, there should always be a reason. If you tell them you just want straight up passives, like, don't say that. Say instead, though, while we're waiting, we'd like to go ahead and settle their bite. So please extrude the whatever, exactly what we just described, to help settle the bite.
Yeah, okay.
Right.
And that's fair.
And then they kind of understand. Yeah, exactly. But if you're like, hey, give me 40 passive aligners because I don't want to use viveras and I'm trying to use these aligners instead of viveras, like, no, that's not going to fly.
Yeah. No, exactly. And a lot of times it would be silly to ask for that on every case because it's not necessary.
No.
In a lot of cases, right?
Yeah. And so then in those circumstances, we would slow down the patients. So they're going to change once every 2 weeks because they're not wearing them all the time. So they're kind of just meant as a holding tray. So like you should be able to get 20 weeks out of that if you're doing the 10 aligners.
Okay. Awesome. Okay. That's a ton of pearls. If anybody who's listening doesn't already is not getting from this that Stephen is like a wealth of knowledge, then I don't know. But I really, again, highly recommend. I've done all of Stephen's courses. I've gone to see him live, and I think Stephen, what I love about you is you're really trying to do things in a very ethical, very scientific. You've time tested everything, and you really want to help GPs really do really good Invisalign, and I admire you so much for that. I know your bigger why, and it's from coming from a really good place. So I know people identify with that, and they really will. Stephen's going to be a star. He's already a star.
Just making me blush here, Becky.
But if you have a chance to hear him live, I'm going to let him tell us a few minutes about some more times or places where they can meet you. But also just tell me quickly a little bit about the different courses, because if you can travel and you want to start doing better, more comprehensive cases sooner than later, just tell me a little bit about your digital courses that you have on demand that you can, and where they can find those.
Sure. I can break down kind of both aspects. So what I've tried to do is I recognize the philosophy of everybody learns differently. And so in as much detail as I try to put into my cases for my patients, I also try with the lecturing side. So I guess the first caveat I'd like to put out is that if anybody ever takes a course from me and you aren't 100% satisfied and you thought I didn't get value from this course, then I don't want your money. I have a full 100% money back guarantee on every single course we do, whether it's online or in person, and I'll still give you the CE even. Now, obviously, if this was being abused, then we'd have to look at it, but nobody has ever taken me up on that. It doesn't happen because my goal...
They would be crazy. I would love to talk to them. Just send them to me.
Okay, Peggy will take care of them. Atlantic Canada style. But I want to do that because it makes me better. It forces me to raise the standard of what I'm doing when I put those parameters in place, because I don't want fluff. I hate that from when I've taken courses. I just can't stand it. I want to give real pearls, and I want your head to hurt by the end of it, because you're like, wow, that changed my world.
Yeah.
So I also recognize some people learn better in person and some are better online. But what is interesting is that anybody who ever comes to an in-person course, I'm also going to give you access to everything we talk about if it's one of the 5 courses that I teach on my own. Those courses are all available online. So I don't want you having to sit with your cell phone up in the air recording everything.
I know. It
I
was
want
so
you to be
good.
able to be in the moment, and then you still have access to everything afterwards that you can access for a year.
And the book you gave us was also so
Thank you.
helpful.
Yeah,
Yeah.
we have almost
Great.
like a textbook almost. It's not
Yeah.
hardcover, but
That's
it's,
amazing.
yeah, thank you. Okay,
Yeah.
that feels great.
Well,
They're
yeah.
pretty expensive to do, so we
I
were
know. So that's
unsure.
why we only took two, because one in
Yeah,
the office and I want one at home. But
yeah,
for every
yeah,
person. But I didn't want to abuse that because
yeah.
I'm sure how much they cost.
Yeah. Oh yeah.
Yeah.
But yeah, so we really want to, like, my goal is to make anyone who comes, like, I want this to be one of the best courses you've ever taken.
Okay.
So if you can't come live to a course, there's 5 courses that I've created so far, and my goal is to create about 15 in total. So the
Wow.
5 courses so far, foundational systems of clear aligners is the first.
Yeah.
And that really goes through every aspect of consults, prescription form. I should take this back a step. It should go through consults, the financial coordinator's role
Yeah.
in finishing the process of closing a case, the assistant's role and the staff's role.
And that was why when I brought my team to that course, we have just been, it's just changed the game. I did the course online way back when you created it and shared that with my team, but it wasn't the same for my team. Like now it's
Yeah.
like, wow.
Yeah, they see it.
Yeah.
So foundational systems, then it's all the office systems. It's all the things that are going to make you efficient and profitable and comfortable with clear aligner therapy.
Yeah.
And this doesn't just hold for Invisalign. It really is meant to be any aligner product that you're using can work in this setting. The next course then is, and so that course is 25 hours of CE, and it's all AGD PACE certified. Then next course is attachments and biomechanics. And so I'm teaching that one live in Calgary in June.
Great.
All of the
They
information
can
for
still
this,
sign up for that, I think.
yeah, can still sign up. It's all available on clearlyaligned.ca.
Okay.
So
Great.
.ca, not .com.
Yeah.
And so attachments and biomechanics, we spend most of the time in Clinchecks. So you're going to be seeing, how do you make the decisions to know what optimized attachments work, which ones don't work, and where would you change the attachments yourself when something isn't going well? And a big part of this is we find it so clinically inefficient to remove all of the optimized attachments every time and then put new ones on, because ideally, if you're using optimized attachments, you should change them out at the end of every
They
set.
don't work in the second.
They don't work very well in the second set based on how the actual attachments work. But the conventional attachments that you can change in the software, those ones can be left on continuously. And then when you have a new batch of aligners, yeah, you don't see the patient for a new delivery appointment. So you don't take off all the attachments and put them all back on. Instead, when you get a new set of aligners, the patient just picks them up from the front desk, tries them in, and then we give all the aligners to all of our patients. And we don't have time to go through that right now, the philosophies.
Exactly.
But in the courses, take the courses. I'll teach you how you never get stuck with patients not paying you. I'll teach you how you don't just become a factory storage facility holding on to thousands of aligners. I'll teach you the most clinically efficient systems in every way, that even if you're a diamond provider, I think you'll get a lot of value to increase your efficiencies. So that's the foundational systems and attachments and biomechanics. The same thing, it's 25 hours or so of content. The next course is diagnosis, development, and treatment planning. So how do you look at a patient's face and understand what you're actually looking at and how they're going to grow and how they're going to change and how to plan things for, like, the smile architecture.
Which is so important now.
Yeah.
Especially it's always been important, but now we realize what we can do with taking that into consideration, right?
Exactly. And how to look at a Ceph and understand that what's happening. So that's diagnosis, development, and treatment planning. Then the next courses that I've moved to create is mixed dentition, part 1 and part 2.
I love those, by the way.
Interesting. Okay.
Well, then because I then started feeling comfortable talking to parents. So even if it was a case that I did or didn't do, I'm having very, very meaningful, helpful, educational even the exams, the recall exams with the parent, I can talk a little bit about what they can expect down the road, and I feel it just makes you feel good to be able to
Mhm.
help a parent who's like their children are everything, right? Like they don't want
Oh
to come for
yeah.
themselves, but if you can open up that part of your practice to doing more mixed dentition, then you're really, I mean, those are your families, right? And they trust you. And if you can do
Yeah.
something for them and sort of step in early to help them and help the parents feel like they have made a best decision, then that's how I felt that that course was just, both of them together. I
Yeah.
mean, you can't do just one. So you got to do both of them.
Well, that feels so great. And why I said kind of like really is just because they're newer courses.
Yeah.
So I hear so much feedback on foundational systems and attachments biomechanics, diagnosis, development. So it's just really nice to get that feedback too,
That's right.
because I know not all providers are ready to kind of take that step. But the ironic thing is that mixed dentition cases, they're the most fun patients to treat.
Yeah.
I absolutely love treating kind of 8-year-olds through 12-year-olds is the best demographic. They're so fun.
Can
Oh,
I
go
just
ahead.
say something? I do
Sure.
find some orthodontists don't want to uh, treat that age. Is that a thing, or is that
Oh yeah.
it's very common
100%.
that they will just
Oh
brush
yeah.
them off and wait
Yes.
until their growth period, they're even past their growth. I don't know. I see that a little bit, and I think
Yeah.
I referred that patient feeling like airway needed to be, we needed to, improve airway in an
Yeah.
earlier
Expand
age, but
arches
they're
and
not thinking
correct
along the
habits.
airway, right?
The reason why is this really is that with the brackets and wires case, it's super, it's not profitable.
Right. And
And
the teeth
so,
are falling out.
and the teeth are falling out, and you can only really bracket the sixes on the back, the first molars and the anteriors. And so like they suck. And I've done lots of mixed dentition cases with brackets and wires.
Yeah.
They're terrible and you make no money on them. But
Right.
the difference is, and this is where I really go into it in the courses, is we can change the entire philosophy of how we treat mixed dentition cases because the aligners don't have to be used continuously. Like braces, if you're going to put them on, they're on until you take them off. And then you're going to put them on for a phase 2 and they're on until you take them off. With the aligners, you can go ahead and start treating these cases and spend like 8 to 12 months fixing all the initial problems, getting everything properly lined up, making sure that the eruption pathways are good. And then they wear them at nighttime. And you see them every year for a checkup, and then you give them a new batch of aligners at nighttime, and you can actually treat these kids at nighttime. So I have kids who I started at 8, 9, 10,
Yeah.
and we did the initial treatment, and now they're like 12 or 13, and we're finishing up the cases.
Yeah.
Well, but here's the cool thing. This is the craziest part. We never went back into daytime wear ever again because we made all the movements happen at nighttime. And so
After at the end, I thought they did go into full-time wear at the end.
I always warn them they might have to.
Okay.
But the percentage that actually end up going back into daytime wear in our practice is probably like 20%. So these kids, you'll ask them, how did you find your aligners? Like they're moving into their final Viveras now. It has been 5 years, but it was only like 8 months
You
of
didn't
actual
feel like
daytime
it. Yeah.
because they're just wearing them at nighttime. So they're the best retainer patients in the world. They're so
It's
good.
part of the routine.
Part of their routine. They just wear trays every
so
night.
good.
And then they say, I don't really remember. And you're like, well, what do you mean? And they're like, well, I wore, like, I remember I was a little, like I was a kid, I was 8 and I wore them for a little bit, I guess in like grade 3 for like 6 months. And then I haven't worn them. And then you compare that experience with parents whose like kids are in brackets and wires at the same time. And so it just completely changes that paradigm. And the parents are just like, wow, I went through braces and headgear or whatever, a twin block
For 5
for
years.
5
in some
years.
cases.
Yeah. And instead
That's
we're
a
doing this at
common story.
nighttime.
And they end up with no bicuspids to boot.
Yeah, totally. So that's what I try to teach in the mixed dentition course
I love
is that, so there's 2 parts to it. And like Peggy said, I think they really do complement each other, but
The
any
second
general
book is more
dentist.
case by like you
Yeah.
show a lot of cases, and I
Yeah.
like that because then I could apply the things that I learned, and also there's so much to be learned, and they're very classic
Yeah.
situations. So they really, once you've done the course, then you go back and do your exams and hygiene, and you were like, whoa, wait a minute, this case is just like the case.
Yeah.
Even, yeah. So that was really good, and you have
Yeah.
to, you can go back and watch it again, which is why the digital is so good to have the
Yeah.
access to that.
Totally. So if you purchase the courses online, you get access for a year. And then after that, you can just, if you want to continue having access, the courses, I think it's like $30 or something like that for like a monthly subscription moving past. So if you don't finish the content in time, we're not trying to like make a whole ton of money off that.
No.
We're just wanting to like have some limitations in place because we don't want to promise forever access.
Yeah.
And then in 30 years, we need to be trying to help give access to these courses. So, so you can keep subscribing afterwards if you want to continue access. There's also packages that are available. So you can get like the core package where you get the foundational systems course, the attachments and biomechanics, and the diagnosis, development, and treatment planning. So you'll save, I think, about $1,000 if you do the package. And then you can do the complete package where you buy everything. And that one, you save more. I think you're saving like $1,500 or $2,000 even compared to what the price would be if you buy them individually.
Yeah, exactly. And I do want to say also, I really enjoy being part of the Facebook group. I'm not always on there, and I have a Facebook group with my course too. And it's not easy, but you know, like what I see is a lot of support on there, a lot of, you know, Kelly's on there. Kelly is your co-host in your podcast, Clearly Aligned. And it's really great to like, anytime. And I know you're always, everybody's a little shy sometimes to put that they don't know something and they're like, okay, is this going to seem really stupid? But it's a really great group. So how do they get part of that? Do they just take the, I mean, I've been part of it for a while, but how do they get into this group?
Sure. Yeah. So we have the Facebook group. Like you said, I really have to give so much credit to Kelly Terrell because
amazing.
She is amazing. So Kelly is a digital treatment planner. She's worked for Align and for ULab. She can design a case like nobody. And we, like, our philosophies are so similar. And that's like, no, she doesn't. She does not. She is one of the hardest working people I've ever met.
I hope you're listening.
Yes. Hopefully your ears are burning somewhere right now. Yeah. So the Facebook page is granted to anybody who takes a Clearly Aligned course.
Okay.
Through like one of the ones that we're putting on in terms of like the Clearly Aligned in individual courses. Because sometimes I'll do collaborations where we might go like we just did a course Beyond the Border with Terry Coddington in California. So we did San Francisco and LA. So we had like 250 doctors or so came to those courses.
And a lot of diamond providers, and they were just like tagging you online. I mean, I follow a lot of them too. And no, yeah, I mean, he's got a really great thing, guys. So if we haven't convinced you, please go on the website, take another look, and
and no pressure. If you try taking something and you're just like, this wasn't right for me.
Money back guarantee, right?
A money back guarantee. I want you to be happy. I really, really do. The purpose of doing all of this is like, I almost view it like a form of art. That like, I'm a purist in the sense of like, I want you to learn the best things. And of course, I want to be profitable teaching it at the same time if it's taking me away from my family and my practice. But I really, really, if it's not like pure in its education and you're not like gaining value from it, then like I don't deserve to be paid for it.
No. I mean, I feel the same way. I feel that we should always give more. Like there should be so much value in our courses or in anything we're providing online or through a Facebook group that the person feels like, wow, I've got such a good deal here.
Yes.
They don't want to feel like they
totally
were paid or anything. And you don't feel like that. So
yeah, totally.
Well, this has been great. Thanks, Stephen.
Oh, thank you. It's so fun chatting.
Yeah, exactly. And we could probably chat a lot longer.
Oh, yeah. And we've talked, so maybe we could tell the viewers too that Peggy's also going to be joining our podcast soon. So we'll...
yes, I'm going to be a guest on your podcast.
Yeah, we'll have you as a guest. And then we can go ahead and pass all the details along there. Because I want to dive into your background too.
Oh, it's complicated, but no. No, I think, we both have a really big passion for what we do. So, you can just talk all day and there's a lot of things that can be gained. I mean, we've both been practicing for a while now. So I feel like if anybody's willing to listen, then I'm willing to share. So I'm really happy to do that. And that's partly why I have this podcast, it's been great. And so thank you, Stephen. I appreciate your time.
Thank you.
If new courses come out, we should get you back on, or if there's something else that changes, we're definitely going to do that. I'll be back again next week, of course, but I want to hear your feedback. Just DM me on Instagram. Everybody knows they can find me on Instagram. And you have an Instagram too now. I know it's not really you operating it, but you can follow Clearly Aligned on Instagram. And and on the website, of course, right?
Yeah. One day I'll finally, for someone like my age, I should be so much better with Instagram, but
No.
you set a shining example.
Everyone is good with it. Like I started doing it because no one knew I was in my area. And then I realized how much of an impact I could, what I was, patients that I was getting through my Instagram. But it's also a bit of a creative outlet. So one last thing is, I would say if somebody said to me, Peggy, what do you love to do? Like what lights you up outside of dentistry? Well, there's like a branch of me that just would do marketing all day or just teach dentists how to do, branding and marketing and feel comfortable. Because a lot of dentists don't feel comfortable on something like Instagram. They don't even they're like, I just don't get it. I don't know it. I don't like it. But what is we just need to know one more thing about you. Like, I know you just started your family, of course. Claire. What did they not? What's one thing probably the general public probably doesn't know about you that to know? Like,
okay,
you're more than just a dentist.
Sure. Oh yeah. Okay. Well, more than dentist. Sure. I'm pretty crazy with a lot of different things. Like I really feel like you need to take the most out of life.
Okay.
So I'm a big traveler. I've been to the Olympics in Brazil, World Cup in Brazil, like slummed it in hostels. I was getting my pilot's license until Claire was born because Amy made me stop. I free dive. So going down on one breath to try to get to the deepest you can and then back up on one breath so I can go down.
Okay, that's really cool.
Yeah. So I'm just like, I'm into like more like experiences, testing the limits of everything in life. So cool. I had to give up my motorcycle though. Amy made me give that up when Claire was born. So
my kids too. My husband had to give up his motorcycle. Yeah.
Yeah. But so I have this other kind of like crazy part of me that I really want to soak up every minute of life.
Yeah. All right. Well, you're definitely an interesting person and I feel honored to be your friend. So thank you again. I really appreciate your time.
Thanks, Peggy.
Yeah. Thanks so much. All right, guys.
Absolutely.
We'll see you guys next time. Thank you so much for listening. I really appreciate you taking the time out of your busy day to listen to this podcast. And again, hopefully I inspired you in some way. If you feel this was helpful or you have any colleagues that you think would really maybe enjoy some of the content like this, we're going to be here every week. And I would so appreciate it if you would subscribe to my channel and also share this little discovery of this new podcast with your friends and colleagues. If you do want to reach me, you can certainly find me through my social media channels, Dr. Peggy Bound or Peggy Bound Dentistry, or you can reach me on my email, peggy@smilesbybound.com.